When patients relapse with myeloma, the type of relapse can be very different. There are patients that have explosive disease, in which case disease control needs to be very rapid. And I think that's a situation for which cytotoxic chemotherapy or certainly a proteasome inhibitor combined with an IMiD or even with an alkylating agent is a very appropriate therapy because that is very good in rapidly reducing the disease burden. In contrast, there's what we call biochemical relapse. These are patients for whom there are relatively no symptoms and their relapse is being detected primarily as defined by blood tests with a slowly rising M spike. And these are patients for whom there is a lot of time to integrate newer therapies. And immunotherapy in that setting seems to be a reasonable choice. You're taking a patient that has minimal symptoms and coming in with a therapy that can take slightly a little bit longer time to respond, but also can be given over a longer period of time. And that is, I think, a situation for which a therapy such as ERD would be a reasonable choice. We can take lessons from the solid tumors, melanoma and lung cancer, where there are tyrosine kinase inhibitors, targeted therapies that have shown for patients whose tumors are expressing certain mutations, a very nice and rapid reduction, but ultimately translating into a relatively short-lived progression-free survival. These are also settings in which checkpoint inhibition has really revolutionized the field. PD-1 blockade has, in contrast, shown, as most immunotherapies do, a slightly longer time to response, but also a longer tail in terms of disease control. And this paradigm, probably best explained in the solid tumor arena, can certainly be applied to other settings, such as in the field of multiple myeloma, where over and over again we are now seeing that a longer time to response can often translate also into a longer disease-free interval. And certainly monoclonal antibody therapies, whether tumor-targeted or immuno-targeted, are reasonable approaches to take in that setting.
There are multiple treatment options now for relapsed and refractory myeloma. Importantly, when we look, I think we can think of different classes of drugs. We can think of proteasome inhibitors with bortezomib, carfilzomib, and now ixazomib. You can think about IMiDs with lenalidomide and pomalidomide. Now we also think about monoclonal antibodies as well with elotuzumab and daratumumab. However, I want to separate those out a little bit because I think that even when we put those two monoclonal antibodies in the same class as being monoclonal antibodies, they're very, very different and very, very different drugs. And so I think we want to be very careful when we talk about monoclonal antibodies to really separate that and say we're talking about elotuzumab or daratumumab and not lump them all together because they're very different, they work very differently. And so I think that's important for our treating physicians to understand. Importantly, we also need to not forget that we also have panobinostat, which is another good class of drugs that was approved last year as well. That's another important treatment options for patients, as well as alkylating-based therapy as well. So I think there's a number of different classes of drugs that we can see. And importantly, I think this highlights really an opportunity to talk about the art of medicine. And so I think that's a key message here is that there are really multiple options for patients. And really we have to embrace the art of medicine and art of myeloma management here. And really, I think that's an exciting opportunity for our patients when we embrace that concept, saying there's lots of opportunities for patients. And so we just have to embrace this as really the art of medicine.
Antibodies currently in multiple myeloma are indicated only in the relapse setting. And this is primarily because that's where the data has been generated thus far, although it's not to say that with more data, these may now move into the upfront setting. I think the current indications suggest or recommend that they be given at least after one prior therapy. And a lot of the therapies are being also examined in combination. So daratumumab was initially approved as a single agent therapy. We have seen from earlier studies that combining that with Revlimid and dexamethasone can increase the overall response rate. At ASCO, we heard yesterday that in combination with Velcade and dexamethasone, there was a dramatic improvement in overall response rate with significant durability compared to Velcade and dexamethasone alone. And I think data is going to be presented next week at EHA showing daratumumab plus Revlimid dexamethasone compared to Revlimid dexamethasone. And I think it's going to also show an improvement in the overall response rate. Similarly, we've seen this with elotuzumab, that the ELOQUENT study has shown that the ERD elotuzumab Revdex has shown a significant improvement in overall response rates compared to Revlimid and dexamethasone. So summarizing these data, I think what we're beginning to see is that antibodies are working through a non-cross-reactive mechanism. There is some benefit of synergism that we're beginning to see, and ultimately what the right combination is going to be of all the drugs that are currently available in the armamentarium remains to be determined. But will probably include an IMiD, may or may not include steroids, may include a proteasome inhibitor, as well as other agents that are currently available. My personal bias, I think, is that drugs that tend to suppress immune responses are probably the ones that will also dampen the response to many of these monoclonal antibodies. And as such, I think it will be interesting, for example, to compare the daratumumab Velcade dex study with the daratumumab Revlimid dex study to see whether there's going to be differences there. Analogous trials are also going on with elotuzumab, where ERD has obviously already been FDA approved, but elotuzumab Velcade dexamethasone is currently being examined as well.